topic. And welcome, everybody. Great that so many folks have decided to join today and learn about this topic. Good morning, good afternoon, whichever applies to where you are. And thank you so much for being here. I'm Joe Ripsum. I'm the Director of Child Welfare and Juvenile Justice Policy here at the Annie E. Casey Foundation. And before that, I spent a number of years working in a couple different jurisdictions and leadership roles in child welfare, youth justice, and children's behavioral health. So today we're going to be talking about collaborating to support youth returning from incarceration, specifically what child welfare leaders need to know about Medicaid. And we know that many young people and their families struggle at the point where various social service and healthcare systems interact. We see this in continuing challenges in child welfare agencies across the country, trying to identify appropriate treatment and placement options for youth and struggling to do so, often resulting in children sleeping in offices, hotels, and other inappropriate settings that are unable to meet their needs or promote the stability or normalcy or family connections that they deserve. Just a week or so ago, we saw a new report based on research from the Bloomberg School of Public Health at Johns Hopkins showing that youth justice systems are reporting an increase in youth being detained or remaining in detention longer than otherwise indicated due to a lack of mental health treatment options. So the policy shift that we're going to talk about today is not a silver bullet to solve these issues, but it is definitely part of how we can collaboratively solve this puzzle. As you'll hear today, the primary policy shift we are talking about relates to new requirements and new opportunities for youth and young adults in the youth and adult justice systems to receive additional supports and services funded by Medicaid. We have done 2 prior related webinars on this topic and have released other materials on this topic, and we'll provide the links to those later in the presentation and in follow-up correspondence. Today's webinar is different from the prior ones, though, because this focuses on the role that child welfare must play in order to allow this new Medicaid policy to improve outcomes for as many youth and young adults as possible. You'll see that there are explicit roles that child welfare must play in order to identify youth and young adults who are eligible for additional Medicaid-funded support and services. And of course, as we all know, the reality is that many youth involved in the justice system are also in the child welfare system, and that child welfare agencies often struggle to find appropriate treatment and placement options for these young people, particularly when they're leaving carceral settings and potentially returning to that child welfare system. So maximizing the new opportunities presented here by planning across the many systems that are involved with youth and young adults can help child welfare agencies support productive transitions and avoid reliance on inappropriate placement settings. Next slide, please. A little bit about the Annie E. Casey Foundation. We are a private philanthropy that builds a brighter future for the nation's children and youth. We want to make sure all young people have family connections, relationships, communities, and educational and employment opportunities that they need to thrive. We focus on children from birth through their mid-20s because research shows young people are still growing and developing until then. We concentrate on young people and families with the greatest needs, including those who have low incomes, live in high poverty communities, and are involved in the child welfare and youth justice systems. And we know that children and families of color often face the greatest barriers to success. Using data as our guide, we develop innovative ideas to address the challenges that these young people and families face. We work with a diverse set of allies across political lines and across sectors to invest in the most effective strategies based on solid evidence and help them reach as many children and families as possible. We know what works, sustainable solutions that emerge when families and young people who have experienced the systems are deeply involved in designing the solutions. Next slide, please. And today your presenters are myself and my 2 colleagues from the Center for Healthcare Strategies, Alyssa Gelber and Liz Buck, who can go very deep into all of this for us. So I'm very grateful to have them with us, and I will pass on to Alyssa. Next slide, please.
Thank you so much, Joe, and a huge thank you to the Annie Casey Foundation for supporting this important work. And so great to have all of you with us today to talk about this topic. Welcome. I am Alyssa Gelber from the Center for Healthcare Strategy. We are a nonprofit dedicated to strengthening the healthcare system to ensure better, more equitable outcomes, particularly for children, youth, and families served by Medicaid. Since 1994, we have worked with all states throughout the country, and that includes work with the majority of states on implementation of the reentry requirements and opportunities that we will be talking about today. Next slide, please. In terms of our agenda, I'm going to kick it off with some level setting. I am then going to turn it to my wonderful colleague Liz Buck, who's going to walk you through some of these new Medicaid reentry requirements and opportunities. I'll walk through some of the action steps for child welfare leaders, and then we're hoping to leave a good amount of time at the end for some Q&A. Next slide. So there's a well-established connection, right, between child welfare involvement and involvement in the juvenile justice and criminal legal system, what we often talk about as crossover youth. Almost half of youth in foster care have an encounter with the criminal legal system by the age of 17. Close to 1/5 of the prison population in the United States have spent time in foster care, and many think that that is an undercount. But while the concept of movement between these systems is important, it can actually obscure the factors that underlie involvement in both systems. Next slide. Unmet health and well-being needs drive involvement in the child welfare system, in the juvenile justice system, in the criminal legal system, and in other public systems. You all know this and see this every day. I am sure you can all think right now of a family that has recently come to the attention of child welfare when the underlying issue was really a lack of access to housing or behavioral health care. And similarly, youth with untreated behavioral health needs or lack of housing are especially vulnerable to arrest and incarceration. Next slide. And this is why, especially why the topic today that we're talking about, reentry, is so key. Reentry, and when we say reentry, we're talking about the period of time both prior to and immediately after return to the community from incarceration, is a critical window that we have to help identify and address these health and well-being needs that contribute to system involvement. When the health and well-being needs of young people are met, when we support their physical health needs, their behavioral health needs, when they have housing, education, employment, safe communities, access to skill development and mentorship, they thrive in their families with their communities. This is the work that you all do every day and the mission of your agencies. The supports and connections that we provide during the reentry period have the potential to help break the cycle of recidivism and further system involvement, and the movement between systems that we talked about earlier. This is really an opportunity to put young people on pathways to better health and to help them thrive in their communities. Next slide. Okay, so where does Medicaid come in? Medicaid is a key source of funding for healthcare services in the United States. Nearly all youth in foster care and youth formerly in foster care up through the age of 26, as we'll talk about later, are eligible for Medicaid. But the long-standing Medicaid inmate payment exclusion, or Medicaid exclusion, inmate exclusion, has long barred states from pulling down Medicaid funding for services provided during incarceration. And even though we are not focusing on CHIP today, there's a similar policy under CHIP called the CHIP eligibility exclusion that has barred states from pulling down funding for CHIP as well. And I'm happy to talk to you about that afterwards if that's important to anybody here. So even though individuals remain eligible for Medicaid, states are not able to bill for those services for the most part. The Medicaid inmate payment exclusion has had broad implications for the continuity of care, both during and after incarceration. For a long time, Medicaid may have been terminated when individuals and youth have entered incarceration, and now in most states, it should be suspended. And the services provided in this pre-release reentry window that we've been talking about have traditionally had to be paid for by state and local dollars. Recent changes in federal policy, though, have altered this landscape, enabling support for the first time by Medicaid for certain services that focus on the continuity of care and allow for the identification and addressing of healthcare needs. I'm going to now turn it to my colleague Liz Buck, who's going to talk you through some of those changes.
Thank you so much, Alyssa. We can actually go to the next slide. So as Alyssa discussed, the Medicaid inmate payment exclusion has contributed to poor transitions of care and often termination of healthcare coverage and missed opportunities to address underlying health and well-being needs. Starting in 2018 with the Support Act and other laws that are seeking to improve continuity of care for youth leaving incarceration, these changes represent a partial amendment to the Medicaid inmate payment exclusion. So in 2018, under the first Trump administration, the Support Act barred termination of Medicaid coverage for eligible youth under Medicaid during incarceration. Passed in 2023, the Consolidated Appropriations Act of 2023, Section 5121, amends the Medicaid inmate payment exclusion and requires all states to implement the provision of screening, diagnostic, and case management services for eligible youth post-adjudication during the reentry period, meaning prior to release and immediately following release from incarceration. In 2023, many states also have approved 1115 waivers that expand these services further, some to include youth and adults. The minimum set of services for 1115 waivers include pre-release services up to 90 days pre-release, medication-assisted treatment, MAT, and a 30-day supply of medications. Next slide. So who are eligible youth within these correctional facilities? So a key focus population for our discussion today are youth under 26 who are formerly in foster care. Other eligible populations include youth under 21 who are eligible for Medicaid and youth under 19 eligible for CHIP, as Alyssa shared. It's important to note that implementation of these requirements includes the juvenile justice system, where many child welfare agencies already have existing partnerships, but it's much broader than that. In addition to juvenile justice settings, state prisons, local jails, and tribal facilities must also implement these required pre- and post-release services for eligible youth post-adjudication. Next slide. So digging into the Consolidated Appropriations Act and exactly what Section 5121 requires. States are engaged right now in the process of implementing these requirements. So really the time is now to become aware of them and to establish partnerships. A key takeaway here really is that as of January 2025, all states are required to ensure that in the 30 days prior to release, wherever possible, youth receive screenings and diagnostics consistent with EPSDT and what you typically think of as a child well visit, and that youth receive targeted case management, which must also continue post-release for a minimum of 30 days. Next slide. States are thinking about how to work with TCM providers to address the many needs youth have following incarceration. And CMS has been really clear in their guidance referring to TCM as a critical linchpin for youth leaving incarceration. The guidance indicates that it should address a broad range of health and social needs, which we know underlies involvement in the justice system and child welfare system. This can include helping with connections to a broad range of Medicaid and non-Medicaid services and supports, including support for skill building, social connections, and education, and more. Next slide. And as I touched on briefly, and I'll go into more detail here, there are also optional opportunities that states are taking advantage of that support youth at the period of reentry beyond the requirements we talked about, that can also address underlying health and well-being needs. So 19 states have approved waivers to improve continuity of care for adults and or youth who are leaving incarceration. States are bringing together Medicaid, juvenile justice, jails, prisons, and other stakeholders to implement these waivers and improve outcomes for youth in the period of reentry. Under the CAA, states also do have the option to provide the full scope of Medicaid and or CHIP services to eligible youth beyond post-adjudication, so those who are pending disposition or awaiting sentencing. So now that we gave that sort of quick overview of these really important policy changes, we will turn to sort of child welfare agency leadership and their role in taking advantage of this opportunity. So I'll turn it to my colleague, Alyssa, for that.
Thank you, Liz. You can go to the next slide. Okay, and before we dig into this, I just want to say that we are really excited and grateful to have this audience together here today. You know, as we have supported states in implementing this work, we have had many conversations over these months with Medicaid, with carceral systems, with JJ, with the criminal legal system, and it's really wonderful to see so many child welfare leaders and staff in the room today because you are such essential partners. So as Liz mentioned, we are going to be walking through some kind of concrete action steps that you all can be taking right now to become involved in and support this work. We're going to go through them pretty quickly so that we can get to your questions, but want to remind you that you can find more information about these action steps in the fact sheet that we will place in the chat and will be available again at the end. So next slide. Okay, so first you want to be joining cross-agency work groups or implementation teams. So as Liz mentioned, there are a number of new requirements, and there are a lot of pieces that will be needed to operationalize these requirements. This will include eligibility and enrollment processes, provider billing, provider access to facilities, looking at the logistics of service delivery, integrating managed care plans, looking at information sharing protocols, and the list goes on. And many of these things require partners working together that may have historically not, worked together much before, including the carceral system and Medicaid. So as you can imagine, this will require a lot of collaboration. And states are, at very different places in implementing these requirements and in planning for implementation of these requirements. In some states, there are kind of well-established collaborations already underway, including justice system partners, community partners, education, faith-based organizations, peers, sister agencies, behavioral health, substance use, developmental disabilities, and so on. And in others, the thinking around this really is just beginning. Kentucky comes to mind as an example of a state that is really building off the foundation of cross-agency work that has happened for quite some time. In other states like Alabama and New Jersey, there are kind of newly formed stakeholder collaboratives that are focused solely on implementing these new requirements. But either way, you will want to find out what types of collaborations and work groups are happening in your state if you are not involved in them already, and make sure that child welfare has a seat at that table because your voice is essential. Next slide. Second, ensure child welfare staff at all levels are aware of the new Medicaid reentry requirements. So the first part of this is really understanding what services are available and available through Medicaid in your state. And this will be different across the country. So as Liz laid out, there are some requirements that apply kind of to all states throughout the country for eligible populations. So as she described under Section 5121 of the CAA 23, all eligible youth, so that was all youth up to 21 eligible for Medicaid and former foster care children under 26 who are post-adjudication are all entitled to those screening and diagnostic services consistent with EPSDT prior to release from incarceration, and also targeted case management pre and post-release. So that's standard. But then depending on the state you're in, your state might also be one of those 19 states that is has approval to utilize Section 1115 waiver authority under a reentry demonstration, and might have a host of other services as well. And those may apply to youth who are pre-adjudication as well. Those might be some of those young people that Joe referred to at the top of the call who are kind of cycling quickly in and out of the juvenile justice system, and for whom you're having trouble finding placement for right now. So it's really important to be aware of what those services are. We know that when services are well coordinated, right, that can enhance the work of child welfare, that can reduce the burden on your staff, and that can definitely improve outcomes for youth and families. And we all know that the opposite can be true when services are not well coordinated across systems, resulting in duplication and confusion for families. Next slide. Review and update formal and informal data sharing approaches. So these new requirements, as you can probably imagine, as Liz was listing them, require justice system partners to coordinate care planning, to do assessments, to provide supports, to establish goals, and to do all of that for some of the young people in your custody. So you will want to do what you can to support that work. And that will include sharing data that is relevant to those youth where it makes sense. So, some of that data that will be important is clinical information, assessment findings, and of course, family permanency plans, and vice versa. You will want to have plans in place to make sure that you are receiving information about what services have been provided to those young people, what assessments and screenings have been performed during their time in carceral settings. I think one thing we want to really emphasize here is that we are well aware that improvements in infrastructure, even small changes in infrastructure, the development or updates to MOUs take a really long time. That can take years. They're costly. And this kind of information sharing needs to be actionable, and it needs to happen soon or now. So we're not necessarily talking about those long-term formal approaches, but actionable immediate strategies that can be put in place right away, even if they're imperfect. Next slide. So in states that utilize managed care, changes may be happening to managed care processes and contracts to ensure alignment with these new reentry requirements and opportunities. And child welfare will want to become actively involved in evaluating these new processes and how they may impact the youth in your care. Many of you child welfare leaders and staff are involved in looking at managed care processes in your states specifically for children in foster care, right? There's work that happens at the child welfare leadership level with your state Medicaid agency and with managed care partners to make sure that the children in your care are getting what they need, that there is alignment between healthcare coordination and child welfare case management. And things may be changing on the carceral system side as these new requirements are put into place. So you want to make sure that you are part of that and paying attention to how that impacts the youth in your care. One question that came up was around responsibility for finding residential or therapeutic placements for youth. And I think this is a really just one example of why this is important. In jurisdictions in which this is carved into managed care, you can imagine that the timing around managed care plan re-enrollment and the managed care plan role in that pre-release targeted case management process would be particularly relevant here, particularly where there are concerns about young people coming out of carceral settings without access to the placements and care that they need on the child welfare side. Next slide. So as we've been discussing, there may be practice changes needed to align with these new reentry requirements, and you will want to make sure that you update policy to reflect those changes in practice and memorialize it. So, for example, you may want your child welfare case managers to be integrated into or participate in that pre-release targeted case management and care planning process, and we'll want that reflected in your policy and training for new case managers. Next slide. And finally, strengthen shared processes for identifying and enrolling eligible former foster care children. So this can be the topic of an entire day's worth of discussion, but we're sliding it in here at the end because it is so important. So as many of you know, there are different eligibility pathways for Medicaid. Under the Affordable Care Act, a categorical eligibility pathway was established for youth and emerging adults who are formerly in foster care up through the age of 26. It is not income dependent. Implementation of the FFCC categorical eligibility enrollment pathway has been challenging in states for a number of reasons, but it is more important than ever. And, just going back to what we talked about at the top of the call, when we think the overlap of these populations between child welfare and juvenile justice and the criminal legal system, one way to think about it is that time in incarceration is a really essential opportunity to look at that enrollment, screening and enrollment, and make sure that individuals who are eligible for that FFCC pathway are properly enrolled in it. Enrollment for youth and emerging adults in FFCC, where they're eligible, means that they leave with their healthcare coverage intact until they are 26. It means that they get that whole host of required services that were laid out under Section 5121 and Section 5122 option if it applies in your state. And it also means that under HR1, they are excluded from community engagement or work requirements. But this is not work that Medicaid and your justice system partners can do alone. They very much need child welfare at the table. So you will want to make sure that you are part of that work and conversation.